So welcome everybody. Thank you so much for joining us this afternoon for our monthly Community Mental Health Transformation webinar. I'm Megan G and I'm the Communications Manager supporting the Community Mental Health Transformation Programme for adults and older adults across Sussex. And today we're joined by Padma Dolby, who is our Clinical Director for the Older Adult and Dementia Transformation, who's going to be speaking to us about, with a real focus on the older adult aspect of the transformation work, which I hope will be really useful and informative for those joining us today. And we're also joined by Oliver Dale, who is our Clinical Director for the Community Transformation Programme, who will also be here to answer any questions that you have throughout the session and in the Q&A at the end of the presentation. So I'm just going to do some very quick housekeeping just to make sure that we're all comfortable and aware of what to expect. So the webinar today will be a 30-minute presentation followed by 15 minutes for questions and answers at the end. This is a live webinar, so do obviously feel free to get involved. You can use the raise hand function, use the Q&A box, the chat box, and I'll keep an eye on that throughout to make sure that any questions and things are acknowledged and responded to as best we can. This session is being recorded and will be added to the Community Transformation playlist that we have on YouTube. So we've got quite a collection of those now, as we've been running these for a year. Actually, it was November last year that we started these. So if you haven't been able to tune into all of those, you are able to watch those back. And I'll share the link to the playlist in the materials that we send around after the session today. And also just to note, because it is being recorded, if you would prefer to keep your camera off, that's absolutely fine. It is whatever you prefer to do, but obviously you are very welcome and encouraged to have your camera on if you're happy to do so. If you'd like to turn on captions for the webinar today, you can do so by clicking the three dots at the bottom of your screen, and you can choose to turn on captions there if that's useful for you. As I say, we'll have 15 minutes for questions and answers at the end, so do feel free to pop in your questions as they come to mind throughout the session. And then after today, I'll send around an email which will have kind of a summary of what was covered, a copy of the slides, and also a link to a short survey, which we'd really appreciate if you can complete. It just helps us to make sure that the webinars are still useful and informative, and also gives you the opportunity to raise suggestions of future topics that you'd like us to cover. So thank you for doing that if you are able. And as I said, all the webinars are available on our YouTube list, our playlist. So I'll send the link to that, but you can also access it through the QR code, which is on the screen now. So I'm now going to hand over to Padma, who will introduce herself and will start our presentation. Thank you, Padma.
Thanks, Megan. Hello, everyone. So Megan's already introduced me. I'm the Clinical Director for Transformation of Older Adult and Dementia Services, and for Community Transformation, very much working in partnership with Oliver. And indeed, across all of the mental health transformation, that's how it works. We don't really do older adults separately, because older adults are part of the whole population. And in Sussex, about 30% of the adult population are over the age of 65, so a really significant part. So what we're covering today is a focus on older adult mental health needs. It's just going to be a little dip in terms of thinking about some of the key facts and figures of why we need to really attend to older adult mental health, and some pointers for people who may not be familiar on how to recognise mental health difficulties in older people. Thinking about what we're doing in the Community Transformation Programme in terms of including older adults. And we've recently launched a suicide awareness campaign for older people. So we're going to be sharing that. So Megan, on to the next slide. Thank you. So first of all, some startling key facts and figures. So mental health difficulties in older people are often unrecognised, unfortunately, and resources that are available to them might be on paper available, but might not always be tailored to their needs. And that can mean that older people's needs are not met. So we've got some key bits of data around the edge there. So older people do self-harm. We can tend to think that that's a younger person's issue, but that's not entirely true. And older people who self-harm are at 67 times greater risk of suicide than the general older population. We also know that if an older person does make a suicide attempt and survives it, they're much more likely to make another attempt and be successful. So that's a really high risk group. Older people in care homes are staggeringly 40 to 60% of older people in care homes have symptoms of depression. So care home populations might be quite a forgotten population. There might be a sense of that person's safe and looked after within a care home, but older people living in care homes do need access to mental health services. And as we can see there, moving on round, the proportion of people over 70 experiencing depression has doubled since the start of the COVID-19 pandemic. Of course, that's across the population. There's been an increase in mental health difficulty. Older adults with complex emotional needs or diagnoses of a personality disorder make up 44% of suicides in the population of people with complex emotional needs. Psychosis is much more common in older age, and alcohol misuse and substance misuse is also significant, especially in that population known as the baby boomers, the people born after the Second World War. Another problem with substance misuse in older people is the misuse of prescribed medication and the overuse of prescribed medication, as well as mixing or polypharmacy as we understand it. In older people, depression is the most common illness, the most common treatable mental illness. And again, another staggering figure that only 4.5% of older people nationally are accessing talking therapies, NHS talking therapies, or IAPT, as we've previously known them. Although once people access those therapies, then they have really good outcomes. And I've got a bit more to say about that when we move to the next slide, if we can do that now. So given all of those facts and figures and many more, that's why in Sussex, we're really trying to take a proactive approach in including older adults in the community transformation programme. And some of the key ways in which we're doing that are featured here. So first of all, we're really increasing awareness of older adult mental health issues across the community to increase referrals into services. So currently our referrals of older people into currently primary care and secondary care services are lower than that of working age adults. So we're trying to level up, to bring up the level of referrals, and challenging the ageism that, well, you're bound to be a bit down if you're old. You know, if my life was like that, I'd be feeling depressed too. Challenging that inherent ageism that mental health difficulties in older people are normal and don't really matter. So in our neighbourhood community mental health services, we're going to ensure that they're open, they're welcoming, and they're accessible to older people, and also that we can reach into where older people live and gather, like care homes, like community wellbeing centres. A big piece of consultation work we've carried out in East Sussex suggested that people would really welcome outreach mental health services into their local areas, community clubs, etc. With moving on around, I don't know which way to go. I'm going to carry on clockwise. Training staff. So in our emotional wellbeing services, those services are going to be ageless. So people of any age, any adults of any age are able to access those services. And to make that really genuine and to ensure that older people really can access those services, we need to train our staff in the skills that are needed to understand the presentations of mental health in older people. And so we're currently working nationally to develop a program of training to support people to reach those competencies. And then finally, we're strengthening the relationships between teams and services that work with older people across physical health care, social care, and mental health care. So for older people, physical and mental health and social needs, they very much interweave. And in our neighbourhood community mental health teams, we've got an ideal of there being no wrong front door into our services, that across the system of health and social care, anybody should be able to direct someone into a mental health service where they can receive the assessment and help that they need. And for older people, a really important part of that is accessing a physical health service, and that practitioner who's seeing that person really recognizing that there's a mental health issue as well, and being able to seamlessly guide that person into mental health support and intervention. So I said I was going to say a little bit more about NHS talking therapies, and I gave you that figure of 4.5% of older people nationally accessing NHS talking therapies. And now I wish I had the figure off the top of my head, but I know that our NHS talking therapies in East Sussex, run by Health in Mind, in the last year have increased the access of older people to their services by 20%. And that's because they've been doing a really dedicated piece of work in terms of understanding what's important to older people in terms of how they want to talk about their mental health, how it feels for them when they've got emotional difficulties, worries, when they feel low, which is the language that they prefer to use, and the kinds of help and interventions that they will find supportive. And Health in Mind do indeed see people who live in care homes. So they've really proved to us, and continue to do so, that with the right work and the right interventions, we can reach older people and meet their needs more effectively. Okay, so moving on to the next slide. So the mental health risk factors in older people, in a way, aren't that different to the mental health risk factors for all the adult population. Loss and bereavement, change in circumstances, isolation and loneliness, physical health, age-related disability, being a carer, having financial difficulties, concurrent alcohol or drug misuse, polypharmacy, and cognitive loss. So those things would make life hard to manage at every age, I would suggest. What happens in older people is that we get a lot of these things coming together, which can create a really complex and difficult to manage picture for the older person. So we can imagine an older person who loses their partner or their spouse, that maybe that person was caring for or supporting them, so they lose their sense of being able to live independently at home in quite the same way. They feel lonely. They're not managing their physical health problems as well. They start to feel quite emotionally low and anxious. Those mental health difficulties might impact further on their physical health problems, make it harder to manage their mobility, their independence. So we can see that a collection of things can start to gather together for an older person. and create quite a complex picture. But that's not to say that they're not going to be receptive and responsive to mental health interventions to help them to manage that. So moving on to the next slide. I'm just taking a couple of slides for those people who are maybe less familiar and working in this field to think about how mental health problems might present differently in older people. So people appearing to be visibly sad or low might not be the most obvious symptom of depression in somebody who is older. We often see a greater focus on the physical, the somatic symptoms, the sleep disturbance, the fatigue, being slowed down, a loss of appetite. And if people have physical health conditions or pain, those might become quite exaggerated, may feel more debilitating for the person. So that might be where the focus is. As in every age, memory and concentration can be affected, but that can appear to be a more prominent symptom in older people. And then we start to get that confusion of, well, is this the beginning of cognitive impairments or dementia, or is it a mental health issue? And people themselves and their families and friends might misinterpret this and just start to say, oh, well, they're starting to lose their memory a bit. And the person themselves might become quite anxious about their memory and their ability to focus and their ability to think things through, and might be quite afraid of facing up to what that means. So again, quite a complex kind of whirlwind of symptoms going on there. We might see a loss of interest in living and wanting to die, which again might be misinterpreted as normal when you're getting that old. Oh no, I'm back. And a sense of the person giving up and feeling quite hopeless. And as I said there, that older people tend to prefer the language of feeling low, of talking about their emotional well-being or their emotional difficulties rather than mental health. And it's really important to communicate that this isn't a normal part of aging, it is a mental health problem. So moving on to the next slide. In terms of anxiety in older people, people might have an underlying sense of fear or dread or a constant nervousness. As in any age group, possibility of panic attacks, avoidance, and worries about health, and as I said in the previous slide, worries about memory difficulties might be there. People might be more irritable, and the normal physical symptoms of anxiety. If the older person is on their own or being cared for, then they might be more frequently seeking reassurance, more frequently checking, not wanting to be alone. And in a care situation, for example, in a care home, it might feel to care as if they're being a bit unreasonable, they're being a bit needy, they're making too many demands. And again, that can be misinterpreted as somebody being attention-seeking, being difficult, which is so unkind, isn't it, when you start to think about it? If somebody spoke about me in that way, I'd feel quite hurt. And, you know, we need to inquire beneath those kind of stereotypes and think, well, what is this person needing? What's going on for them? And actually, they're experiencing a mental health problem. And older people prefer to talk about having worries or having nerves, being nervous in general. Okay, moving on to the next slide. So this is something that we've been working on as part of the transformation program as a whole and part of the suicide prevention program. And it's a campaign that was originally launched in Greater Manchester a couple of years ago. And it's called Don't Brush It Under the Carpet. The idea that encouraging older people not to dismiss, not to brush away their emotional difficulties, their symptoms of not being well emotionally, not having good mental health, and really raising awareness that older people are vulnerable to both self-harm and to suicide, and really encouraging older people to speak up about this, to not think that it's a normal part of aging. They're not being too much trouble, they're not being a burden to others by talking about their mental health difficulties, and that there are treatments and interventions available that can help. And that phrase, a problem shared is a problem halved, trying to use that language of don't hide it away, all on your own, share it with other people. So we're really proud and pleased, and very much want to share that this campaign is out there. We launched it last week. So moving on to the next slide. That's the other. So what I showed there was a postcard, which is one of the resources that we've got, and this is the back of the postcard with the resources that we're signposting people to. Moving on. So within the Don't Brush It Under the Carpet campaign, we've got a whole suite of physical and digital publicity, which we can direct you to. So we've got a dedicated suicide prevention website, which is delivered in partnership with Grassroots. And we've also got posters and postcards, which we can send out to services. We can send you a digital poster, or we can send you lovely physical ones. Hopefully people are going to start noticing things popping up in GPs' surgeries, on the whiteboards, on the screens, posters in pharmacies, and our posters and postcards out there in the community. We've also created what we're calling a talking toolkit, which is a downloadable resource which guides friends and carers who are concerned about an older person into how to recognize potential suicidal thoughts that aren't being spoken about, and how to open that sensitive conversation about what a person might be feeling, encouraging an older person to speak about their suicidal thoughts rather than holding them close to their chest, as it were. Yes, so Megan is going to take us into that website for a little quick look. So this is the Grassroots website, and you can see straight away, if somebody goes into that website, they can say, I'm having thoughts of suicide, and click on that to immediately get signposted into where to get help, or a carer or relative or a professional can click saying that they're worried about someone else. So if we just scroll down, what I want to do is entice you into having a look yourself. So we've got a lot of local resources there that people can click into and access. And then these blue buttons here, we tackle what are the risk factors, the warning signs, myths around suicide and self-harm in older people, and the talking toolkit. So if we click on the suicide myths, so straight away we've got a really good myth there, that people reach a stage when they just give up in life. And this can be quite common in care homes. People have had a lot of loss, maybe a loss of their own health and independence. They move into a care home, and the care home staff think, oh, look, the person's just giving up. It's time for them to go. It's time for them to die. People neglect eating and drinking. They might be unwilling to get out of bed. They don't have much motivation to participate in day-to-day activities. And there might be, people might not know that person very well. They might have lost people around them. There might be not anyone who really knows that person well to advocate them and say, well, this isn't my mom, this isn't my dad. They're not usually like this. it's not a normal life stage just to give up. It's a sign of depression, and older people in that context can be supported. Then Megan, if you just click back to where we were. Oh, right, that's fine. I was going to show one more thing. That's fine. So, oh, she's so responsive. I was just going to suggest you click on the Talking Toolkit. And this takes us into a downloadable resource, which can be printed off, or people can download to their phones or their laptops. And it takes a person just through a kind of confidence building guide in terms of how to talk to an older person they might be concerned about. Thanks, Megan, that's fine. And then on the website, you don't have to go back, but on the website, there's also access to some brief courses and training resources in terms of how to talk to any person, but including older people, about suicidal thoughts. So I think that brings us to the end. Let's click on and check. Yeah, so that's the end of my presentation. It probably wasn't as long as half an hour. Oh, it was. There you go. So we're happy to open up to questions.
Thank you, Padma. So yes, it's now over to those attending the webinar today. If you've got any questions, feel free to raise your hand, or you can put them in the Q&A box or in the chat box, and we'll keep an eye on it. But yes, the next 15 minutes is over to all of you to ask any questions you've got. Mel.
It's not so much a question, it's a comment. You've really taken aboard something that I've seen a lot of other trusts haven't, is that different people, different styles of communication, and this is not all digital, which has backed a lot of constituents off, and it's made them more reticent. And this shows so much attention to what we've been hearing, and it's really addressing it. And when it's possible to tell people, oh, I hear there's something going on, then do let me know, because a lot throughout COVID, a lot of people have had their faith in the trust really restored, because they've seen how much they've been listening. And this is a superb example of actually you're looking from every angle.
That's fantastic, Mel. Thank you.
Thank you.
Thank you, Mel. Does anyone else have any questions at all for Padma or Oliver today? Glenn, would you like to ask a question?
Yeah, hi there. I'm mindful when we hear about community transformation for adults and older adults that dementia isn't mentioned within that, and I just wonder what messaging we want people working particularly in dementia services to receive with regards to community transformation.
Good question. So in Sussex Partnership at the moment, as I know you know, Glenn, but not everybody might, our community mental health teams for older people work with both older people with complex mental health problems and people living with dementia, because we really see the overlap between those two groups of service users, and it can be quite difficult to tease apart in many people cognitive difficulties or dementia and mental health problems. And we do take an approach in Sussex Partnership that when somebody has complex difficulties associated with living with dementia, mental health is often or nearly always included in that picture. So we have the same workforce working with both those groups. And as we move into the neighbourhood community teams, our intention is to keep that workforce working with both of those groups, because that clinically we think that's the best model that we're going to take forward. The emotional wellbeing services are very much geared towards mental health rather than dementia, and there are different dementia pathways in terms of detecting memory difficulties, assessing and diagnosing, and supporting following a diagnosis. So we continue to work on all of the dementia pathways. So there'll be a little bit of an interweaving. Is like basically the community mental health transformation is about mental health, but our teams within those will be working with people with dementia. We'll be working with carers of people with dementia. There's good evidence that cognitive behavioural approaches in supporting carers of people living with dementia are really important. Yeah, I feel I'm rambling in trying to say we are really thinking about dementia care pathways, and there's definitely an overlap, and there's also a sense in which they're separate. Does that make, am I making enough sense, Glenn?
Yeah, absolutely. Yeah, thank you.
Oliver, did you want to add anything at all?
No, I think well, Padma sort of covered it very well, I think, and we want to retain the flexibility of the neighbourhood mental health team being able to work with older people, because sometimes I was talking to Padma about my own practice, and I've got a particular interest in suicide actually, and people who are experiencing suicide experiences, and so I was reflecting on negotiations with a colleague where there are other areas where I'm not so good at, so dementia, and when you get the earlier presentations in dementia where mental health difficulties and they come all a bit jumbled together, and that's a real specialism that I'm not particularly strong on, and so I was so we want to have a sort of flexibility so that the most suitable person in our system is able to respond to the individual's needs, and at the same time ensuring that we have good access to specialist older adult services as well. So I think Padma sort of described the vision. At the moment, I think our sense is the emotional wellbeing service is still trying to make its networks, and therefore, because an awful lot of the wellbeing intervention will come is a bit emergent really, and it really depends on the locality and forming relationships with other sort of people within the neighbourhoods and so on. So that's something we need to monitor, because Padma and I have a sense that we're not actually really responding to those needs as best as we should be. But so it's something that will definitely be a work in progress, I think.
Thank you both. We have got a question in the Q&A box from Carol, who said, in one of the previous slides, it mentioned training for all staff regarding being able to help older people. Does this mean that there will be a change in the way that working age mental health services and specialist older adult mental health services teams work within the community?
That's a big question, isn't it? Because there's going to be a lot of change in terms of how those teams work in the context of being in the wider neighbourhood networks. And I guess I'd want to echo what Oliver just said. Oliver was talking about just thinking about his own skills as an adult psychiatrist, and where he might sometimes have greater confidence in working with a certain kind of presentation, like an older person who's presenting with suicidality, compared to his colleague working with an older person with a complex older age picture of a mix of physical health and cognitive changes and mental health. So what we're really wanting to think about, and it's already our strategy and within the trust, is looking at a needs-led service where people get their needs met by the most appropriate clinicians and teams. So for the most part, I would think that older people presenting with complex mental health problems would continue to best get their needs met by specialist older adult mental health teams. But I'd really like to welcome the opening up of services and interventions where that might not currently be the case. So as Oliver said, in emotional wellbeing services, but also, we might be offering group interventions, like the adult teams currently might be offering some group interventions that aren't accessible in some parts of Sussex to an older person. And we don't really want to exclude older people from any kind of support and interventions just because of their age. It needs to be, what best meets a person's need. I don't know if that answers your question, Carol.
Yes, it does. Thank you.
Great, thanks.
Thank you. Liam, you've got your hand up. Would you like to ask a question?
Yeah, thanks. I mean, it may be too soon to say, but I was wondering if you have any thoughts about what will happen with proactive care and what will happen with crisis teams in the new model from an older person's perspective. Because proactive care is not that different, is it, to emotional wellbeing services in terms of where it's sort of sat or what it was intended to do, really?
Yes, so the proactive care teams, I'm not really on top of what they do. You're talking about the couple of West Sussex teams, aren't you?
Yeah.
So I honestly, I'll have to come back to you on that one.
Yeah, that's all right.
In terms of crisis care, so yes, our crisis response and home treatment for older people, the model across Sussex Partnership has been to provide that from all age adult teams. And as you might be aware, Liam, we've long advocated an approach whereby we develop a more specialist and attuned intensive support service that would work with older people with mental health problems and people with complex presentations of dementia.
Yeah.
And that is a model we're continuing to want to develop. I think we've probably got that a little bit more established in West Sussex than in other areas. And it's all a matter of gradually finding the resource to make those teams possible. At the same time, the urgent care pathway has many elements to it. So the intensive support model we'd really like to develop for older people and dementia would be just a kind of 12 hours a day model. So it wouldn't be to exclude people from other resources in the urgent care pathway, especially at other times, if that was relevant.
That's really helpful. Yeah. Thank you for that.
Can I add something to that? Because I suppose I've been reflecting on what it is that we're, trying to conceptualize what we're trying to do with the transformation program. And one of the key things is the creation of both a public health model and a partnership approach. So the people that use our services and the people that refer to our services, frankly, find it quite confusing because there are lots of different services, lots of different pathways. All with slightly different inclusion and exclusion criteria. Some of those services criteria mean that they can't work alongside other services. And sometimes we ask one service to refer to a neighbouring service. So it's very confusing. It's also risky. And the consequence is quite often people give up or get, and sometimes that means they don't then get the help they need. And so really one of the fundamental things that we're trying to do is to integrate and bring together. So we create these neighborhoods where clinicians actually can hand over work to one another without frustrating the patient, without introducing confusion to colleagues or delays. And the other thing, which I think is quite important, is that sometimes in that sort of system, we have a tendency to signpost people and say, go and have a look at this service. And we make an assumption that they're going to be able to manage it, or they're going to have the energy to see it through, or it's the right thing. Sometimes they go off to something that's not the right fit for them. So there's also a way in which if we are able to get these neighbourhoods, that we can accompany people as they are wandering or going around our broader system. So the neighbourhood team, the core neighbourhood mental health team, is a sort of an organising, holding space where the key components are drawn together and they sit within a broader network around them. And it's really quite complicated to sort of get across. So I hope I've sort of done it some more justice. I don't know, but yeah. So I'm also really interested, Liam, in I think you call it proactive care. I've never heard of it. I've only been here 6 months, but I'd be interested to hear about it some other time, perhaps.
Yeah, that's fine. Yeah, I think at one stage they tried to have multi-agent or multidisciplinary teams in primary care with mental health practitioners working alongside other health professionals. There was a notion that, you know, an area, a bit like like you described neighborhood teams, that those teams could be as large as maybe 40 people in a team. Not really quite sure that it ever, you know, quite got there. But we do have practitioners who are you know, using GP systems, recording on those systems, or sat in primary care, are doing some of that filtering in terms of at least discussing referrals or taking on some short pieces of work. So that exists certainly in parts of West Sussex, but probably not everywhere. But yeah, definitely in West Sussex it still exists. So yeah, it'd be just useful to think how they might link in with just, you know, emotional wellbeing services or the neighbourhood team. Yeah, thank you.
Thank you, Liam. I think that's probably all we have time for, as we're at 1 minute to 1:45. So I will bring our webinar to a close. Thank you to everyone who has joined us this afternoon, and to Padma and Oliver for leading the session. Thank you to everyone who asked any questions. And obviously, as always, if you do think of something that you wish you'd asked once the webinar has finished, please do still get in touch with us. I'll send around the notes from the session, and you can respond to that email, which will come through to the Community Transformation Programme team, so we can then respond to any questions or comments that you've got. And that mailbox is open, so you know, it doesn't just have to be about the webinars. You can contact us there about other points as well. And then just to share, the next webinar will be on Wednesday the 20th of December. So our last one of the year. So do sign up for that if you haven't already, and encourage your colleagues and people within the groups and networks that you work within to join as well. Yeah, we'll send around more details about that later on today as well. But yes, thank you so much for joining, and we look forward to seeing you all again soon. Have a good rest of the day.
Thank you.
Thank you.
Thanks. Bye, everyone.
Bye-bye.